Good morning, everyone. Today I will be presenting on alcohol use disorder, commonly known as AUD, using a clinical case study of 25 years old white male. This presentation will cover the epidemiology, risk factor, clinical finding, differentials, abnormal lab findings, and full plan of care. Alcohol use disorder is one of the most common and most underdiagnosed substance use disorder we encounter in a clinical practice, and understanding how to assess and manage it is a critical skill for psychiatric mental health nurse practitioner. Epidemiology. Let's start with the why this topic matters. According to the National Institute in Alcohol Abuse and Alcoholism, approximately 28.9 million Americans currently have alcohol use disorder. This is a struggling number. Among adult age 18 to 25, prevalence is 10.6%, making this age group one of the most highest risk population, which is directly relevant to our 25 years old patient today. AUD is 2.5 times more common in the male than women, and white male especially have some of the highest rates nationally. Despite how widespread it is, only about 7% of people with AUD ever receive a treatment. This treatment gap is enormous and point to the to the need for the better screening and early intervention. Economically, AUD cost the United States approximately $249 billion every year in healthcare, lost productivity, and criminal justice costs. It is also ranked the third leading prevalent preventable causes of the death in United States. As you can see in the bar chart, prevalence peaking in the age of 18 to 25 age group and steadily be declining with the age, reinforcing that early screening in a young adult is essential. Risk factor. Now let's talk about the what puts someone at a risk factor for developing AUD. Risk factor for factor falls into the three main category: biological, psychological, and social or environmental. On the biological side, genetics play a major role. Research shows that 40 to 60% of the risk factor for AUD is heritable. Male Male sex increase the risk by 2.5 times compared to the female. Early onset of the drinking before age of 15 dramatically increase the lifetime risk of developing AUD, and co-occurring mental health conditions like depression, anxiety are both risk factor and common comorbidity. Psychological: individual with a poor impulse control, trauma or PTSD history, low distress tolerance, and sensation seeking personality are at a significantly higher risk. This trait often drive people towards alcohol as a way to cope or self-medicate. Socially, environment, peer pressure, and college drinking culture are major contributing factors in young adults. Stressful life events such as job loss, relationship problem, easy access to cheaper alcohol, heavy media, and advertising exposure all increases the risk. For our patient, especially a 25 years old white male who began drinking at 16, he falls sequentially into the high risk demographic across all the three categories. This is exactly who we need to be screening early and aggressively. Subjective and objective finding. This slide covers both what the patient tells us and what we observe and measure clinically. Starting with the subjective finding, what the patient report. The common one include drinking 8 to 12 beers per day and drinking alone, craving alcohol first thing in the morning, multiple failed attempts to cut back, social and job related consequences from drinking, and experiencing fatigue, nausea, anxiety when he does not drink. These are the classic withdrawal and dependence syndrome. The uncommon findings are equally important. Our patient denies morning drinking to his family, which signals a denial and minimization and a hallmark of AUD. He also reports blackout episode 2 to 3 times a month and has been hiding alcohol at his workplace. This behavior reflects a more severe and intrudence pattern of alcohol use. On the objective slide, clinically we observed tremors, sweating, elevated heart rate, all sign of alcohol withdrawal. His blood pressure is elevated at 142/88. His AUD score is 11, which is in a severe range. We also see slurred speech, unsteady gait, and liver tenderness on examination. Less commonly, we may find peripheral neuropathy presented as tingling in the feet, parotid gland enlargement for chronic alcohol use, spider angioma on the chest, which which suggests early liver disease. This common finding tells us this is not early stage AUD. This patient has been drinking heavily for a significant period of time. Differential diagnosis and workup. When a patient presented like this, we must consider several diagnoses before landing on AUD as our primary diagnosis. First, AUD itself, our patient meet 8 out of 11 DSM criteria over the past 12 months, which confirm the diagnosis and classify it as a severe. Second, alcohol withdrawal must be identified and managed concurrently with his tremors, diaphoresis, and tachycardia. We use CIWA protocol to assess severity and guided treatment. This is a medical emergency if untreated. Third, major depressive disorder is common on comorbidity. Alcohol marks depressive symptom, and it can be difficult to distinguish primary depression from alcohol-induced mood disorder. We treat the AUD first and reassess mood after a period of severity. Fourth, anxiety disorder. Our patient report anxiety when not drinking, but this is consistent with the withdrawal rather than primary anxiety disorder. Finally, recurrent encephalopathy is a less common but life-threatening complication of thiamine deficiency seen in the chronic alcohol use. We screen for it with confusion, ataxia, and eye movement abnormality, and we always check thiamine level. For our diagnostic workup, we use AUDITC or full AUDIT screening tool. Check CBC, CMP for anemia and metabolic issues, liver function test, GGT, and MCB, which are sensitive markers for heavy alcohol use. Blood alcohol level, urine toxicology, TS and TSS to rule out the thyroid issue that can mimic the mood symptom. Potential abnormal finding. Chronic heavy alcohol use effectively affect virtually every organ system in the body. This slide highlight the most important abnormality finding by the system. In the liver, the most common affect organ, we see elevated AST, ALT, in GGT, and AST to ALT ratio greater than 2 to 1 is classic marker of alcohol liver disease. Over time, this progresses to fatty liver, alcoholic hepatitis, and cirrhosis. Cardiovascular findings include hypertension, which occurs patient already has as well as cardiomyopathy from the direct toxic effect of alcohol on the heart muscles, arterial fibrillation, and prolonged QT interval on ECG. Neurologically, chronic AUD causes cortisol atrophy visible on the CT or MRI, peripheral neuropathy from B12 deficiency, and in severe cases, wrinkle-Kassoff syndrome, potential irreversible brain disorder caused by the thiamine deficiency. In the blood, we commonly see macrocytosis, meaning enlarged red blood cells reflected in elevated MCB along with anemia and low platelets. Folate deficiency is also very common. Gastrointestinal and metabolic complications include pancreatitis, GI bleeding, and electrolyte abnormality. Low magnesium, potassium, and phosphate are especially dangerous. Psychiatric depression, anxiety are nearly universal. More severely, patient can develop alcohol-induced psychosis and significant cognitive impairment over the time. Suicidal ideation must always be assessed in the patient in this population. Plan of care, pharmacological and non-pharmacological. Now let's talk about the treatment. Comprehensive plan for the AUD include both medication and therapy. On the pharmacological side, naloxone 50 mg daily is our first line FDA approved medication. It works by blocking the opioid receptor and significantly reduce the craving and reinforce the pleasure of drinking. A compressed 666 mg 3 times a day is a good alternative, especially if naloxone is not tolerated. It reduces the discomfort of prolonged withdrawal. Disulfiram can be used as a deterrent, but only in the highly motivated and closely monitored patient because it causes a severe reaction if alcohol is consumed. For withdrawal management, we use chlordiazoxide taper guided by the CIWA protocol. Any patient with a score above 10 or higher with a withdrawal seizure should be supervised. Thiamine 100 mg IV or IM for 3 days is mandatory to prevent wrinkle encephalopathy, and folate 1 gram daily corrected the nutritional deficiency universally present. On the non-pharmacological side, motivational interviewing is typically our first therapy step. It meets the patient where they are and build internal motivation to change. Cognitive behavior therapy helps to identify triggers and healthier coping strategy. 12-step program like Alcoholic Anonymous and evidence-based alternative like SMART recovery provide a critical peer support. Mindfulness-based relapse prevention is an emerging evidence-based approach that reduces the craving that through emotional regulation. And for the patient with a severe withdrawal, medically supervised inpatient detox is the safest option. Plan of care, education, psychosocial, and referrals. Treatment does not stop on the medication and therapy. A truly patient-centered plan addresses education, health promotion, psychosocial need, and referral. For the patient education, one of the most important things we can do is to help the patient understand AUD is a chronic brain disorder, not a moral failure of lack of willingness. We explain how to naloxone work, what side effect to watch for, and that alcohol and naltrexone together can be dangerous. We can clear the goal whether that is abstinence or reduce use, and we teach him how to recognize early relapse and warning sign. For the health promotion and maintenance, we counsel on nutrition science. Chronic AUD deplete multiple vitamins and minerals. We encourage regular exercise, which has been shown to reduce craving. Sleep hygiene is important because poor sleep is the both trigger and the consequence of AUD. We also make sure hepatitis A, B vaccine are currently, since alcohol use increases the infection risks, and we schedule annual lab to monitor the liver and metabolic function. Psychosocially, we assess his support system. Does he have a family involved? His housing stable? Is he employed? We address financial and social stressor and connect him to peer support group. Peer support group. Cultural consideration matters to stigma around addiction affect help seeking behavior, and we approach this with compassion and non-judgment. We also screen for intimate partner violence, which is struggle associated with AUD. For referral, we coordinate with the addiction medication specialist, licensed CBT, MI therapist, primary care for ongoing medical monitoring, social worker for housing and employment resources, and especially psychiatric if comorbid depression or anxiety requires separate treatment. This is the last slide of mine. It's a reference. You can look the reference. What are the reference I have chosen for this presentation. Thank you so much for your time. If you have any question, please reach out to me. Thank you. Have a blessed day.